Excellent. Thank you. Well, hello and welcome to this, the Royal College of GPs webinar on QOF QI, entitled Leading Effective Sustainable Quality Improvements Within the Primary Care Network, or PCN. We know that you're likely to already be familiar with recent QOF changes to include QI and with the introduction of the National PCN DES. So QI is something which we've all been involved with in many guises for many years, either directly or indirectly, knowingly or unknowingly. And its value and importance has been recognised by all of the main health and social care bodies. It affects our lives as clinicians and all of those in our general practice teams, and in particular this year in two ways. So both in QOF points and the changes there, and as part of the PCN DES. So we have undertaken one webinar so far in how to approach a quality improvement in your practice, and a further two are scheduled over the next month, focusing specifically on the two QI domains in QOF this year. So they are the early diagnosis of cancer and care of people with learning disabilities. Great. So what can you expect to take away from this session? So we are hoping to make things easier regarding effective planning and organisation of these meetings, especially getting the right stakeholders on board. We're hoping to help you achieve more from your PCN or peer review meetings, according to the guidance, and also to emphasise the benefits of showcasing and celebrating our progress made between meetings, and to really extract the most out of shared learning. And we'll be presenting some relevant case study examples as we look at the ways in which you can galvanise, support and align effective improvement activity within your network. So before introducing the panel, I briefly want to cover some housekeeping. We'd like to make the video recording of this webinar available to people who were unable to attend tonight. So we're going to focus on the slides and the presentation in the first half, and we're going to respond in the second half. So if you have a question, please send it to us via the Q&A option on Zoom, down near the bottom. We've disabled chat to ensure that we can easily moderate questions coming in, but we haven't disabled the hands up function. But we won't be using it this time, as we want to focus on presenting the content to ensure a good flow, so we stick to time. If we do run out of time and we can't answer all of your questions, we will endeavour to follow up with you offline. So please do send through questions in the Q&A throughout the presentations. You don't have to wait till the end, and we'll pick them up as we're going along and aim to answer them at the end. So what is QOF QI? So this year's QOF QI modules, they are early diagnosis of cancer and care of people with learning disabilities. And to support these and previous QOF QI modules, NHS England and Improvement commissioned the college, the RCGP, in collaboration with experts from various organisations, which include NHSEI, the Health Foundation, NICE, Hull York Medical School, and the college, plus a huge range of learned colleagues, co-authors, and contributors. All of this since 2019. And we've produced 10 QOF QI modules and accompanying resources. So this year we've been busy producing learning materials to support general practice to carry out the QI activity relating to the two modules, but more generally guidance on how to approach QI, and specifically QI at PCN level. So hopefully that's why we're all here today. For more information on this work, please visit look at the links on the screen. And we can share the slides after the webinar, so you have those and other links which are relevant. For those that can't see the screen, it's rcgp.org.uk/QOF QI and qiready.rcgp.org.uk. And lastly, if you're on Twitter, you can find us holding Twitter chats and promoting resources by searching for the hashtag QOF QI and @RCGP. So I'm going to introduce Liz and Brian and Sai independently so they can describe themselves. My name is Mike Jones, I'm a GP. I'm currently leading the caretaking process of a small practice in East London. In addition to that, I'm the Deputy Medical Director of a group practice based in South East London, and I'm one of the RCGP's National Clinical Champions for Quality Improvement. So can I start by introducing Liz?
Thanks, Mike. So as you know, I'm a senior lecturer at Hull York Medical School. And as part of my role there, I try and enthuse and motivate medical students and physician associate students to take on quality improvement in practice. And I undertake research in implementation science to try and find more appropriate and acceptable ways to speed up the pace of evidence into practice. Over to Brian.
Thanks, Liz. I'm Brian. I'm an Improvement Fellow at the Health Foundation. And the Health Foundation is one of the partner organisations, as Mike said, that's involved in the development of the QOF QI modules. So over to Sai.
Thanks. Hi, I'm Sai Ganesratnam, Sai for short. I'm a GP principal working in Merton in southwest London. I'm a PCN clinical director, and I work as a medical director with our PAM PCN partnership in Merton called Merton Health in a hybrid role with community services. And I work as a medical director with the Southwest London Primary Care Federation Alliance for Southwest London, which is an alliance for 6 federations, and the London rep for NHS Confederation is on the PCN network board.
Thanks, Sai. So what are we going to talk about today? One of the many excellent resources to accompany this webinar can be found on the QOF QI mini site, rcgp.org.uk/QOF and it's a how-to guide, and it can be downloaded as a PCN on the brain. It can be downloaded as a PDF, but it's also neatly summarized on the mini site. And this wheel, which you can see in front of you, sets out the 6 recommended steps of the PCN's improvement journey. They're a guide. We will help you to plan, to deliver, and to hopefully sustain quality improvements across your PCN. Drawing on learning from across primary care and the wider NHS, we intend in this webinar to set out the skills, the behaviours and the actions that underpin successful quality improvement interventions. So let's start by hearing from Liz.
Okay, so leadership is where it all begins. Your primary care network needs someone like you to plan, deliver and sustain the coordinated QI activity. Leadership is all about you being and maintaining enthusiasm and building commitment from all stakeholders in your network to coordinate people from a range of backgrounds, including patients. We want you to be able to speed up the ability to work collaboratively to improve how care is organised and experienced by both staff and patients. So when planning your improvement activities, it's really important to draw on the learning and create a shared improvement ambition. You can focus primarily on identifying what are the common frustrations and the aspirations of your staff. They have all the answers that you need to tap into to try and make care better. It's nothing magical, but it's all about building good relationships. You've got to try and ensure that there is a culture of learning and that you involve everyone that is relevant in their role, regardless of seniority. This is particularly important because if you feel safe and supported, then it is more likely to unleash your creative ideas. And that's what you need. You don't need an improvement initiative that's evidence-based that won't work for your institution. You want something that people will accept and work on. Much of these ideas come if you can protect time away from the normal clinical admin and management responsibilities. And I appreciate that the current climate makes that very challenging to do. But the more time that is spent taking time to plan and initiate just the smallest, simplest changes, these can have the biggest impact, and they can have a sustained impact, and they can continue the cycle of making people feel safe and listened to, and making sure that changes actually result in improvements in how care is organised and experienced. you will find that you have the knowledge to identify the existing expertise within your network. This existing expertise can be used to also enhance capability by continuing to incrementally increase the confidence and the QI skills of others in your network, by capitalising on the opportunities for shared learning, or by trying to find resources. There's a wealth of QI resources out there from the RCGP and the Health Foundation, for example. But you can use your network expertise to identify the things that are particularly helpful and easy to implement for people just beginning their journey, and for those hoping to advance and tailor their skills. When you're deciding what changes to deliver, it's really important to align the QI activities to provide support and coordinate expertise. There are far too many priorities for implementation, and it's really important to start small and coordinate those changes so that you can benefit from shared learning. This will hopefully continue to sustain your improvement work if you can build a culture of learning to fail fast and continue to improve on what matters most. And I'll hand over to Brian next to talk about the next element on the wheel.
Thanks, Liz. So I think it's important to remember that improvement is, as we know, first and foremost, team game. We know that no one person can solve pathway or system-wide challenges on their own. I think that's why it's really important to get together a group with the right blend of skills, knowledge, and experience of the problem you want to tackle. And so what do we mean by this? So first of all, finding people who know where to access the right performance data and are skilled in analysing and interpreting is key. Secondly, and equally important, is specialist clinical knowledge of topic areas, detailed knowledge of local and national priorities and policies, and experience of service redesign and improvements. And I think time spent assembling the right team at the start will pay rich dividends later on. So I think one of the challenges that we at the Health Foundation have always seen is a lot that people tend to sort of look for solutions before they've actually spent time on the planning and the development. So spending that time, building relationships, working out who should be involved is absolutely critical. And it's not just about the core team. So it's also about assembling that kind of wider group of stakeholders. Not all of them are going to be part of that team, who will also help to build momentum for change and encourage buy-in, the eventual intervention. So that's really important. And then, as well as involving the right people, you also need to take time to identify what's already working well in your network and try to understand what's made them successful, learning from them, and where possible, building on what they've already done, and publicly acknowledging the strengths of existing practice where it exists is important in building goodwill and trust. And I think that's absolutely important, because one of the things people often struggle with is the next revolution, the next improvement journey. But there's plenty of evidence, there's plenty of goodwill, there's plenty of experience, there's plenty of good practice already out there. So identifying that, spending time speaking to people is so important. So I'm now going to hand over to Sai, who's going to give us an example from his work.
Thanks, Brian. So this particular example here is a proactive care home pilot that we delivered as a primary care home a few years ago. So primary care homes are an example of a primary care network, and they were sort of the precursor to sort of the PCN sort of DES framework that we see now. And one reflection is that in terms of harnessing their expertise, it's really about how you take advantage of those local informal relationships that you have. So although you may feel as a clinical director, there's this sort of hierarchical structure around you where you've got CDs, and then you've got your borough partnerships, and then you've got that ICS, which is somewhere up in the clouds. In reality, it's about harnessing those local relationships. And I found it really helpful working with our commissioners, with the staff at our care home, our practices, and our staff within our practices on this particular project. And we actually did a staff survey, which is not just of our practices, but also of the care home staff working in it as well. And we also engaged with our PPGs to sort of understand what was important to them. And we used that information to then go to our CCG. And when we spoke to our commissioner, she actually said to me, Sai, actually, we've noticed a slight challenge. We've noticed that your care home has lots of LAS conveyances. It's actually in the top 5 in the borough. Maybe we should try and do something about it. And so she helped us get the data that we need to look at, to think about the model of care that we want to develop for this particular group of patients. So that led to us then developing a particular care plan for these patients, a process by which we did ward rounds, worked with the care home on MDTs, undertook feedback surveys on the experience, not just for patients, but also the relatives and the staff. And we put together a business case that allowed us to then continue and extend that beyond the 6-month pilot period. But that was all possible because everyone was vested and interested in delivering this project. The CCG were interested, the care home were interested because we'd done a survey and they told us this is what they wanted to focus on. So that really was pivotal to the success of this. So that informal, almost social network we developed across sectors and across providers and with staff and patients that allowed us to deliver this project. And we achieved a 30% reduction in LAS conveyances as a result of that. So there was a clear sort of demonstrable benefit in terms of that sort of hard outcome. But also when we did the feedback surveys, there was really positive patient experience and staff experience as well. So the care home staff are really happy that practice are now proactively working with them and speaking to them. They hadn't had that before. So, you know, on all levels, it worked really well. But it was underpinned by that informal relationship network that we developed, harnessing all that expertise. Back to you, Brian.
Okay, I think I'll be Brian for now. Thanks, I. Well, as you know, there are always lots of priorities for improvement, and your network needs to collaborate to maximise improvements in how care is organised and experienced in areas that matter, not just nationally as dictated by the various improvement schemes, but within that, prioritising what will matter most locally as well. And there's a number of different steps to this. Firstly, you can use your data. Wherever possible, try and use the data that's out there already that you don't need to gather yourself, and make the most of existing systems like the Atlas of Variation, or whether there's CCG or public health data that's available that you can use to identify those that are doing well and those where there's room for improvement and could benefit from additional support within the network. Where you do need to then move forward into providing more either recent data or more practice-specific data, can you share existing tools, existing searches, templates, for example? Make the most of those collaborative learning opportunities. Once you have data to see whether there is actually room for improvement, you need to then understand more about why there's variation underlying that data. And this requires a different type of data. This is a good opportunity for you to really talk to people, to have improvement conversations, and to use tools within QI methodology like process mapping to really outline all of the processes that cause frustration or duplication. And then from there, identify who's doing well, what is it they're using that could be shared. You can then identify the right people as well who might be able to support the people that need more resources to help make things better. So this can involve both members of staff with seniority who have power to control perhaps resources and time, but you also need staff who are really good at influencing each other as well and help and support to help make it a safe culture for change and to create that culture for learning. This can often be done by embedding time on the agendas within existing meetings so that you try and make QI more manageable, and it's not just another thing. If you can capitalise on finding agenda time within existing meetings, you can also maximise engagement of particular staff groups that you might particularly want to engage in. It's really important, as Brian said, to find the right combination of skills and expertise, including topic knowledge, systems knowledge, quality improvement methodology, patient experience, and knowledge of appropriate change interventions that may or may not work in the right context. So I'll pass you back to Sai, who'll be able to give another example of how this can work in practice.
Thanks, Liz. So this particular programme was a PCN diabetes QI local incentive scheme, which is really the culmination of a 2 years worth of discussions and work. And initially we were looking at data, and there was a mixture of different types of data we were looking at. So there was lots of qualitative data that came through our local authority and the work they did with communities, which is called the Diabetes Truth Programme. And that was really listening to the voice of patients and the real lived experience of the care they were receiving, and how they thought it could be different or could be improved. We also looked at practice, QOF outcome data, and things like the NICE treatment targets, which were being collated at both a practice level, but also at a borough and a South West London level. And from a Merton perspective, we looked at it at network level as well, because we'd organised inter-networks at that time. We also started to segment that activity using a tool initially called Solace, and we then moved to something called Eclipse, which looked at particular types of patients who had diabetes, so patients who might be on 2 or more agents, patients who might have severe mental illness, so specific types of groups of patients, to see what outcomes they were having, what effect they were having on the wider system, and also what kind of care they were receiving. And we were looking at all this together and realized it was quite complex, and actually it needed a more structured approach. So we actually formed a diabetes program board. So it was an alliance and a coalition of the willing, with all the resources that we need to try and hopefully drive transformation in Merton at every level. So we had representation from the CCG, from all those who were providing diabetes services, so practices, but also the tier 3 and tier 4 providers. We had community and patient representatives. So we had a full gamut of representation on that program board. And through that, we worked towards a new model of care for diabetes in Merton. And where we landed was we realized that we had to do things at different levels. We realized that practices had actually significant large diabetes populations. When you talk about PCN, actually a single practice could easily have 600, 700 diabetic patients. They had significant numbers of patients, and we realized that we really need to deep dive into how practices were delivering care. So part of the service we provided was an annual deep dive at each practice, where we looked at all of their processes. We had conversations with everyone in the team involved in delivering diabetes at the practice, and we put together an improvement plan for that practice, and we would go and visit that practice in a year's time. We also realized that obviously diabetes is a condition that's not managed in isolation by the practice, it's by all the partners involved in that patient's care. So we also delivered MDTs at primary care network level, and these weren't discussing every single patient, because obviously that would be happening through practice, but this is where we would bring together interesting cases that were anonymized, where we discuss that with community services. We often would have Health Watch attending sometimes as well, and we'd sort of come to conclusions, share learning, and that information was also then aggregated at PCN and borough level, and then disseminated borough-wide as well. We also formed something called a diabetes advisory service, which was basically a specialist service for clinicians to access if they weren't sure what to do with the patient, where they could email or call as well. And at the end of the year, we did a thematic analysis where we pulled together the learning from the deep dives in the practices, the learning from the MDTs, but also the feedback from that specialist advice service as well. And we had an ongoing diabetes truth program. So that golden thread was really the patient voice and that lived experience of care throughout it all. And that was how we then moved to a different model of diabetes care. Now, one thing we did realize is that this is something where it's really hard to evidence some of the harder outcomes, harder impacts, because with something like this, actually improvement takes years. So although you may be doing the right thing now, you may not see the benefit for at least a few years. And obviously we hit the COVID pandemic, so we are restarting and re-evaluating where we are as we speak. But I think that's a good example of how we really bring together that alliance of the willing to look at a project like this.
Brilliant. Over to Brian.
Thanks, Si. And I think that's a really good reflection on how long it takes sometimes to see the impact of some of the changes that you put in place. It can be months, years sometimes before you're really getting the kind of benefit of those interventions. So as we've already highlighted, it's important to bring on board people with the right technical and clinical skills and experience when you're designing and delivering an improvement intervention. But those skills, they're really only one part of the equation. So relational skills are equally, if not more important at times. You need people who enjoy working in collaboration, who are willing to listen attentively to others and ask the right questions, or just as importantly, pose a constructive challenge at the right time. Systems thinking skills are also important, again, such as the ability to spot connections and synthesize ideas and information quickly and effectively. And then, as with all improvement work, the capacity to deal with that inevitable uncertainty and risk that comes with change also matters a lot. As we know with improvement, things very rarely go to plan, and it's important to be ready for that. It's also crucial to bring in patient experiences from the start, right from the very start, before you're even at the very start of that planning process. So they have a central role in driving change. So they're not just a consultee and about something that's already been decided, but they're in the driving seat. But this does mean thinking really carefully about how to involve them in a meaningful way, so they're not isolated at the sidelines. So that means thinking carefully about what role they're going to play, how they're going to be supported, how they're introduced. So that's absolutely essential. And then finally, it's also useful to remember that your support needs will change as your work develops and evolves over time. You need continuity in that core team, absolutely, but you may also need to bring in people with specific skills and expertise at certain points of that improvement journey. So you really need the ability to look ahead and actually identify those needs early, so you can bring those people in at the right time and with the right sort of lead in. Okay, so I'm going to hand over again to Si for some more insights from his work in South London.
So I think this is really interesting because as a CD, it can be quite daunting thinking about how you triangulate information and knowledge to help you deliver what you want to do for your PCN when you're thinking about QI. And so I realized that it's not something I could do alone. And I think, again, it's about how you tap into those, or at least develop those informal networks in your area. So, starting with at my PCN, I very quickly realized I need to identify leads for particular areas and harnessing the skills and expertise that was available. So I have a workforce lead who is specifically focused on developing the workforce, and that's the clinical and the non-clinical workforce. We have a communities lead who's responsible for working with patients. So we have individual practice PPGs, but we also have a PCN PPG that meets quarterly, and our community lead is responsible for talking to the PPG representatives on key PCN issues, and that's how we learn and get that feedback, because really you can't do anything if you don't listen to patients. And that's, I think that's really resonated with me from the COVID experience in particular, when you think about the vaccination program, where I think we've never been more engaged or connected with our communities. We've got a care home lead, because obviously that's an important part of the DES. And we actually more recently have a digital lead now, because we realised that actually we've gone through a tremendous amount of digital transformation. We have a cancer lead, because we know that's really important in our area. We've got a very deprived area. And we have an overseeing sort of managing director who looks at things from a sort of managerial perspective. Our PCN size is about 50,000 patients. So we're a big-ish PCN, but not super big. And these roles are not sort of, six-figure salaries or seven-figure salaries. They're not substantive roles in that way, just to be really clear. So we've used our £1.50 and just said to someone, can you dedicate 6 hours a month on this? We're not giving them massive portfolios of work to do, but what we are doing is we're giving people specific focused areas to work on and saying this is what you're going to prioritize, and we agree that together collectively, and we triangulate feedback from other parts of the system when deciding what we prioritize. So you can, as a PCN, have leads, but you've just got to use your time wisely, and you've also got to develop and nurture that leadership as well. From a transition and ICS perspective, we also have a primary care senior leadership team as well. So you do need to tap into other networks. So when you think about primary care and you think about what specialist expertise you need to tap in from a primary care perspective, primary care is not just general practice. It's also community pharmacy, optometry, dentistry. It's also the primary care expertise that resides in the CTG, and it's the LMC as well. So primary care voice and primary care feedback is quite complex when you think about it. So we have got a network of senior primary care leaders within our borough. You then got your place partnership and your place team, and then all the people from that sector as well. And then at ICS level, we have a primary care provider alliance also. All these networks talk to each other. They're not hierarchical, they're quite flat. So we've developed those relationships. We've worked hard to do that. And I think as a PCN CD, it's those informal networks that hopefully will enrich your sort of lived experience as a leader, and will help you to then deliver those QI projects for your PCN. So it's not your knowledge alone, it's that shared collective knowledge that you draw from your networks that I think is so important. Back to the team.
Okay, so how do you go about bringing all these people together? Well, one of the positives of COVID is that it has rapidly expanded the options for meeting face to face. There's never been such a deluge of different options for meeting via Zoom, Google Meet, Teams. And whilst it might be mind-boggling to try and get your head around all the different functionalities of these different options, they do give you much more flexibility about bringing people together in smaller groups or in larger groups as you feel the need with different stages of planning and design and operationalization of your projects. Whilst you're using these different things, it is really important to think about how you want to show everyone to show up, have a voice, and feel listened to. As we did at the start of this meeting, we talked about different options about expectations for cameras, raising your hand, or whether it's appropriate to use the text box facility or not, whether you want people to have to take turns at being heard. With all of new technologies, it depends on knowing who the audience is. You will know these people better. You will understand whether there is a flat hierarchy, as Sai has mentioned previously, or whether you will be bringing people together in new collaborations for the first time and trying to build a sustained partnership that you want to see going forward. You've got to use these things appropriately, and whilst we can give recommendations in the guidance, it's really important to think of these new meetings as a form of quality improvement activity in their own right. What works for your network might be different from what works for another network. With all these ideas, start out slow, consider what you want to adopt, what you need to adapt for the next meeting, or what you need to abandon and start again with another option. Continue to use the lessons that you learn and also the lessons that you learn from the other primary care networks, and continue to share these on the Twitter chat as well, so that other people can benefit from novel ideas about how to ensure that we get the best from these collaborative working groups. And I think Sai has another example for us.
Thanks. Yeah, I must confess, I was sort of thinking, what do I share here? Because I'm probably not the best person to give a Zoom tutorial or an MS Teams tutorial, but I thought one thing I can say is that when I start a virtual session, I normally put this slide up, which is like a housekeeping slide, just to set the tone for the session. So I hope that is helpful. So, and going through some really basic things you wouldn't otherwise think of. I mean, how often might you have someone munching on a packet of crisps, for example, with their microphone on? So, you know, it's worth just sort of highlighting some basics around how the virtual sort of session will work and making it really clear what the purpose of the workshop is, that it's a safe space, what those sort of rules are, you know, the rules in terms of engagement within that session. So I think that's always useful to do a housekeeping slide at the start of any session. That's just one example. It's not the best, it's not the worst, but always think about a housekeeping slide. Next slide, please. And then within the sessions, I think there's different sort of techniques you can use. So this is something from some engagement sessions that I was delivering around sort of developing primary care voice in Merton as part of NHS transition, and collating views and making people feel that they've been heard. And so someone came up with the idea, it wasn't me, but one of our managers said, how about a chat bubble? So we then invented the phrase, the Merton chat bubble. So at the end of the previous session, we sort of share the chat from that session and capturing what people said. And I thought that was a good way of sharing what we're hearing, and hoping that resonates with the audience, and so that they know we're listening to them and taking that forward. And then using the next slide as another example. Here we asked some questions which we need some answers to, and the answers really came from the audience. So sharing what you've heard, what you've learned as a means of moving forwards, again, is an example of how you're facilitating improvement and sort of taking people with you. So they're just two examples, but I think the key message is really using your virtual sessions to sort of harness the thoughts and feedback of the audience and then relaying it back to them so they feel like they're being taken on a journey and they're being listened to, and then linking that to very clear constructive actions that everyone signed up to. Back to the team.
Great, thanks, Sai. So as we know, delivering a successful quality improvement intervention is incredibly rewarding. but no one should pretend it's easy. There's going to be plenty of setbacks and challenges on the way, lots of frustration sometimes. And also you have to find ways to juggle not just your improvement work, but everything else that's going on in your lives, professionally and personally. So I think it's really important to celebrate those moments, each step of your improvement journey. Those moments, the ability to take a breath and sit back and congratulate yourself on what you've done, not just when you've developed something valuable that be sustained at the end of that journey. So it's crucial both in terms of maintaining momentum and confidence in the team, but it's also good for external stakeholders too. So showing people in your locality that you're doing something worthwhile and important that you yourself think is important and valuable. That's really important. I think another big lesson from a lot of the work the Improvement Health Foundation has funded over the years is celebrating that work externally really helps to raise the profile of the team and what you're doing. So don't miss any opportunities to do that. And as well as another crucial part of this is in highlighting what you've achieved and the individual and collective contributions of the team. Now that's also going to stand the team members in good stead when they come to reflect on how they develop their careers and what options are open to them. Because some of those kind of problem-solving skills, the management and leadership skills you learn from doing improvement are absolutely invaluable. And there are so many people who have risen up the kind of the ladder based on they've cut their teeth and developed some really important sort of confidence skills on the back of improvement work. So celebrating success at every turn is absolutely essential, I think, when it comes to doing improvement. Right, I think we've got one more from Sai's bag of examples.
Thanks. So, I mean, I think in terms of celebrating success, and I think we all do that in our own way. So there isn't a prescribed way that you celebrate success. So yes, we have done PCN newsletters in the past. We've done meals. The one that sort of resonated and connected with me the most from my own personal experience is when you celebrate and connect and engage with your community at the same time. So this is a very recent photo from the bank holiday weekend where we did a PCN health and wellbeing fair. So we wanted to celebrate the fact that lockdown had lifted. It was a bank holiday weekend and, you know, we're all still standing, but we also wanted to connect and engage with the community. So you can see you've got the town mayor there standing in the background. We're doing some 40+ health checks nearby. And there was a stand there where we were doing some dancing as well. I won't share that video. I don't want to traumatize the audience, but we had fun, we enjoyed ourselves. And I think the fact we could host a fair like that where 1,500 people came with, you know, representatives from health and care on the stalls, practice teams out and about on a weekend, I think is how you know that you are celebrating success as a network. And my reflection as a sort of PCN clinical director is very much also when you think about leadership, it's not just you alone. I think the leadership style that served me best is acting as a servant leader, where really it's asking others what they want and helping them deliver what they desire. I think that's really important. And probably the other useful way of delivering QI is, and this is something that was discussed just a few weeks ago with our medical director, is I think adopting an approach where you're a thought leader. You're not necessarily in control doing it all, but you're sharing ideas and thoughts that motivate and change how others do things. So you may not always get the credit, but you have a positive impact on those around you. And I think as PCN CDs, primarily we have to be servant leaders, but also thought leaders, where we're changing thoughts and minds, hearts and minds of those around us as well. I think that's how you have that ripple effect and deliver real change and hopefully make your PCNs a success.
Thanks so much for those examples, Sai, and for talking us through all the benefits and how to undertake successful quality improvement with your PCN. So this slide you've seen before, I think it was slide 2 or so, and I just wanted to highlight again what we think we've tried to convey to you today, with some really on the floor grassroots GP examples. So hopefully you feel like you'll be able to achieve more from the PCN meetings, hopefully from a baseline of perhaps being not necessarily leading the meetings, but certainly engaging in them. You may well feel more compelled to take on the QI element. Simultaneously, we described how to organise the meetings, and this can be backed up with, like I said, the document which is on the college website under the QOF QI mini web page. And then, yeah, showcasing and celebrating progress maybe between meetings. It sounds like a no-brainer, but we often don't do it. We often forget about that bit. And, you know, it really does help to inspire and to motivate people to continue doing what they're doing well, and hopefully attract more people to help with the improvement effort. So quality improvement is not going away. So I think we're all still learning and benefiting from hearing what other people are doing. And then maximizing the shared learning and how to sustain. So sustaining, I suppose we probably all agree here, is one of the hardest elements. And, you know, once people's concentrations are taken elsewhere, perhaps if funding is removed, how do you maintain all that good work ticking over in the background? So hopefully the slides that we've shown and talked through will help with that as well. So question and answers. So if you haven't submitted a question already, I recommend please do now. We have a few minutes left to go through them. One of the first ones I'd like to put towards probably Si. Well, if I can focus on Si to start with, and maybe have Liz and Brian chip in, would be, I think it was your slide 10 or 11, was your pan-PCN diabetes slide from 2016, 2018. And I know you didn't have loads and loads of space to write, but what you did describe and what you documented were all of the positives that came out of this, which is what we really need to hear, what we want to hear. But secretly, I suppose it'd be helpful to know, and to maybe to make it more realistic to everybody watching today, be interesting to know, is there anything you can advise or tell us about any of the challenges that you encountered along the way that maybe that we could perhaps avoid making those same mistakes, or that we could reach our end goal a bit sooner if we just known about them earlier? Is there anything in particular that you found hindrances or hitches along the way?
And the catalyst for that was the program board. So we probably had too many separate conversations in silos until that program board came together. So bringing all the key stakeholders together earlier and sooner would have made a big difference.
Right.
I think the other big challenge was the data. As you know, there's so much data, there's so much of it, and with something like diabetes, you present things like, you know, segregated data sets, stratified by risk and all that, and you can sometimes get lost in the data and lose sight of what you're trying to achieve. So maintaining that objectivity about what your end goal is, and I think sort of listening to patients, knowing what they want to achieve, what they'd like to see happen, listening to your teams on the ground about what they're experiencing in terms of the care that they're delivering, helps you, I think, retain the objectivity. So I think the data was a challenge. I think the third challenge is probably organizational sovereignty, if I'm honest. So when you're redesigning a service and you're adopting a system approach, there's obviously negotiating investment in primary care for a LIS scheme. That investment has to come from somewhere. So there were some very complex CCG financial calculations, and don't ask me how they worked it out, where they looked at anticipated shifts in activity from one part of the system to another, and then the potential savings for reinvestment. And that's always speculative, but you need buy-in from all the partners when you're doing something like that. Part of it was trying to sell in the vision of how we want to work together, and encouraging other providers, for example, like secondary care, community service, to work differently and think out of the box. And that doesn't necessarily mean a consultant physically leaving the hospital to work in the community, but it does require consultants to work in different ways. So there's some of the challenges that we did encounter. And that's why it took 2 years. But it would have been a bit quicker, I think, we'd set up the program board sooner.
I think that's crystal. No, it's really helpful. And hopefully that's one thing that people can take away today. That'll be at the forefront of their minds.
And I think just to come in on that, it's really important to almost flip our ideas of which data is important, because there's lots of number data right there that says we should be doing this for lots of patients. And it can become very overwhelming, especially in conditions like diabetes, when you look at the searches and you identify hundreds of patients that need care to be done differently. And you're already working at maximum capacity, and there's just no room to see where you could do things differently. Whereas if you flip the coin and think about what could we do less of, and what really matters most particularly to staff, where they can identify where there's redundant or unnecessary steps and paperwork and things, small things to get the ball rolling initially with a change that would make an impact to reduce workload, and thinking about just what are the changes that would matter most to patients. And if you can find that hook, all professionals want to make care better for patients, but it's starting small with the processes, the paperwork, the easy quick wins that you can show success and gain momentum, free up a little bit of capacity in a time that's so overwhelming for clinicians. But at the same time, capitalizing on that impetus, you know, COVID has made people think about doing things radically differently that they thought would never happen in primary care. We've seen huge leaps forward and improvements for staff and for patients. And hopefully this is a good time to capitalize on those benefits.
Yeah, and I think Liz is absolutely right. It's about thinking about waste and duplication. I think those are the things that, you know, appeal so much to kind of patients and clinicians. Never about efficiency. It's about kind of thinking, well, how can we make things better? What can we lose? What can we get out of the way? And I think also one of the important things when you're thinking about kind of any improvement project is thinking, as Si says, about those system relationships, because it's one thing kind of building a relationship within your own practice, within your own kind of immediate body. But when you've got sort of an improvement intervention that sort of impacts on so many different partners, one of the things that people consistently underestimate is just how long and how difficult it is to sort of build those relationships. And often, sometimes, what you think might be a problem isn't actually a problem. It's perhaps because it's how you perceive one of your other stakeholders in your area of acting. But it's when you actually build those relationships, things begin to move. But that is one, I think, in our experience, one of the biggest challenges when you're trying to do improvement at scale across multiple providers with very different aims and different objectives, and as we say, different kind of financial and kind of models in play.
The diabetes, the board that you created, Si, I mean, I see that as one of the ways in order to get people together. I suppose you have that sort of shared purpose. But I was wondering from one or all of you, whether you could answer perhaps how we can encourage wider participation in quality improvement from not only from practice teams and not just from the CDs, you know, coming from each or even the PCN leads in each PCN, but how can we encourage wider participation in QI from practice teams, from voluntary organisations, and from community services? What can we use to make things easier, to catalyse it, as you say? Brian, I suppose you mentioned the benefits of the reduction in waste and duplication, but I think there's probably more draws than we give ourselves credit to for engaging in QI.
Yeah, and I think one of the things about the first and most important thing is demystifying it. I mean, a lot of organisations may have had limited experience of doing improvement or getting involved in improvement. It might seem a bit daunting, it might seem a bit challenging, but actually when you realise, it's about giving people the opportunity, the space to do things differently. There are plenty, any person, any organisation can get involved, but sometimes you need a bit of support. You need to actually kind of get that kind of input from others to show you the way. So I think there's something about, there's a responsibility for organisations like the Health Foundation and others is to really kind of push out those kind of messages and actually kind of help people understand what it is they can do themselves and in partnership with the teams around them to change things. And I think it's examples as well, small examples showing how people in similar situations as yourself have made change is really, really important. And coming back to the early question about kind of what are the challenges, I think people will have much more faith in something when they can see that it went wrong in places and how it went wrong, what you did to learn from that. And I think those kind of honest examples of how change happens, coupled with that kind of attempts to try to demystify what improvement is, are really important.
Yeah, I think on the back of that, it's making that a safe space, because if people feel that they're being listened to and can have a voice, and it's breaking down those barriers. So there's leadership roles for people, which may be appropriate, but if you can have space for people to offer up novel solutions as well. We all know that, you know, a PowerPoint presentation isn't going to change things, but how we go about thinking about novel innovations that might be out with our comfort zone. For example, when I first started working with a team that we're trying to introduce shared hemodialysis care for patients who want to do more of their own dialysis tasks, a lot of the clinicians were quite resistant because they thought it was all about efficiencies and job cuts. Whereas the healthcare assistants, once they were given a voice and they were listened to and heard, they were part of the leadership team that made it a safe space, brought it forward, came up with the change ideas that would work to help implement the change across the rest of the team. So making use of everyone, from anyone with experience in IT, healthcare assistants, physician associates, whoever is in the admin team. There's lots of different skills and experiences there to capitalize on if you can bring those people together and couple the improvement science aspect with the novel aspects of what would really work for us. We know our culture, we know our context, we know the history that we're grappling with, we know where we want to go. What are all those barriers that we need to resolve, and what are the facilitating factors? If you can bring those two aspects together, then you can create some really impactful changes.
It's just what we wanted to hear. Thanks very much, Liz. And thanks, Brian. And thanks to Sai. I appreciate we're 5 minutes from the end, so I thought good opportunity to tie this up. We will look at collating any unanswered questions and sending the responses out to everyone. And it wouldn't be a proper webinar if I didn't ask you to complete the short evaluation questionnaire that we sent to you in order to let us know what you thought of the webinar, how we could do better, what should we do differently, that sort of thing. Equally, it would be remiss of me not to plug some of our other outputs. So we have already undertaken a couple of podcasts on the current QOF QI modules, so Cancer and LD, and they are available wherever you download your podcasts. There are 2 more webinars, which I mentioned before. There's a webinar relating to care of those with learning disabilities, and that's on the 21st of September. That's a Tuesday. And then the following Tuesday, the 28th of September, will be a webinar all about early diagnosis of cancer. They are searchable and bookable on the RCGP events page, and links will be included in the evaluation email. So it was great to have Sai on today to discuss some of the case studies or the examples which he's work that he's undertaken, but there are more case studies. There's top tips, there's PCN guidance, and plenty more on the RCGP QOF QI webpage and QI Ready, and links will be shared, as I said. So thanks once again to the panelists, Sai, Liz, and Brian. Thanks especially to you at home for taking the time out to join us. And we look forward to seeing you at the next webinar. Take care.